Hello everyone. I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. So in this session, I'll be doing a quick recap on this topic of the hypercalcemia. So starting with that, first and foremost, you need to know how much is the normal calcium level in our body. So in our body, we have the total calcium and as well as the free calcium or the ionic calcium. So the total serum calcium is around 9 to 11 milligrams per deciliter, and that is the bound form, right? I mean to say this is the bound form. And the ionized calcium or the free calcium, it is around 4 to 5 milligrams per deciliter. So when I use the word bound form, it is the one which is bound to the albumin. Now, when you use the word hypercalcemia, what does it represent? It represents increase in either the total calcium or increase in the free calcium level. That is what you mean by the word hypercalcemia. And almost 98% of the calcium which is present in our body, right, it is stored within the bone. Having said that, yes, so if you see the regulation of the calcium, so calcium, it is reabsorbed from the intestines, right, with the help of vitamin D. It is absorbed from the intestines and it is also reabsorbed from the kidney. And once the calcium enters into the circulation, right, it is being distributed to various organs. So 98% of it, right, it is being distributed within the bone. Now you have to understand that there are two important hormones which will try to increase the serum calcium levels. One is the parathormone and the other one is the vitamin D. These are the two hormones which will try to increase the calcium levels. Whereas we have one important hormone which will try to decrease the calcium level, that is the calcitonin. So parathormone, it will increase the osteoclastic activity and it will cause bone resorption and it will increase the calcium level. Whereas vitamin D, it will increase the calcium level by reabsorption of calcium at the level of the duodenum. Whereas calcitonin, it will decrease the calcium by inhibiting the bone resorption. So these are the three important hormones which will regulate the calcium level of around 9 to 11 milligrams per deciliter. Having said that, now what exactly is the site of absorption of the calcium within the GIT? So please remember, it is within the small intestine, and within the small intestine, particularly in the duodenum, the calcium is absorbed with the help of vitamin D. Next. And about 80% of the ingested calcium load in the diet is lost in the feces unabsorbed. 80% is being lost in the feces. And what are the fractions of the calcium? So of the calcium, whatever is available and circulating in the blood, free calcium, it is 50%. Protein bound calcium, it is 40%, with only 10% which is bound to the citrate or the phosphate buffers. So we have totally three fractions. And what is the most common cause of the hypercalcemia? So if you see the most common cause of hypercalcemia, it is mainly one of the very important endocrine disorder, that is hyperparathyroidism, and that is particularly primary hyperparathyroidism is the most common cause for hypercalcemia. And in primary hyperparathyroidism, what is the most common cause? It is parathyroid adenoma, right? That is the most common cause for hyperparathyroidism. And this particular hyperparathyroidism or hypercalcemia, it is usually asymptomatic and it is found as a result of the routine testing. Next. Now, apart from hyperparathyroidism, we have some other endocrine disorders which can contribute to the development of the hypercalcemia. Now, that includes the hyperthyroidism. See, thyroid hormone, whenever it is increased in quantity, it will stimulate the osteoclasts. Right? So by stimulating the osteoclast, it will cause the bone resorption and thereby there will be hypercalcemia within the individual. So we have two endocrine disorders. One is hyperparathyroidism and the other one is hyperthyroidism, which will cause the hypercalcemia. Then now we also have some malignant causes for the development of the hypercalcemia, and that important include squamous cell carcinoma of the lung. See, the squamous cell carcinoma of the lung, it will produce parathormone like protein. Right, it will produce the parathormone like protein. So because of the release of this parathormone like protein by the squamous cell carcinoma, which will cause increase in the osteoclastic activity and it will cause the bone resorption. Okay, next. Then followed by that, metastatic disease of the bone. So these are the two malignancies, squamous cell carcinoma of the lung and metastatic disease of the bone. Next, followed by that, there are certain granulomatous conditions which will cause the hypercalcemia, and these granulomatous conditions include sarcoidosis, which is characterized by deposition of non-caseating granuloma, then tuberculosis, which is characterized by the caseating granuloma, then berylliosis, then so all these are associated with the development of hypercalcemia, which are your granulomatous diseases, that is sarcoidosis, tuberculosis and berylliosis. Now, and at the same time, let me tell you, there are certain fungal infections which will cause hypercalcemia, and these fungal infections which will cause hypercalcemia, it includes the histoplasmosis and the coccidiomycosis. So let me tell you, this histoplasmosis, it is also associated with the adrenal insufficiency also, right? It also causes the Addison's disease as well. So please remember, these are the fungal infections which will cause the hypercalcemia. Now, the question is, just now we were discussing like sarcoidosis, tuberculosis and berylliosis, they cause hypercalcemia. Now why is that these granulomas will cause the hypercalcemia? The reason is that the neutrophils in granulomas, they have their own 25 vitamin D hydroxylation, right? Yes, definitely I understand granulomas are the granulomas are the one which contains the macrophages, and remember they also contain the neutrophils. Okay, so the neutrophils in granulomas, they have their own 25 vitamin D hydroxylation, right? And that is what is responsible for the production of the active 1-25 vitamin D, which will cause the calcium reabsorption from the intestine. Then, now, what are the drugs which will cause the hypercalcemia? So the rare causes that include vitamin D intoxication, thiazide diuretics will cause hypercalcemia, lithium use will cause hypercalcemia, Paget's disease, right, as well as prolonged immobilization will also cause the hypercalcemia. So lithium is the drug used in the treatment of the bipolar disorder, and Paget's disease, it is a malignancy of the bone. So the drugs, if you take vitamin D intoxication, thiazide diuretics, and as well as the lithium use, so these are the one which will cause the hypercalcemia. Now, the other important thing is, if the individual is having acidosis, there will be development of hypercalcemia. Now, how the acidosis causes the hypercalcemia? That is, acidosis, it results in an increased amount of the free calcium, right? That is what I am trying to tell you, right? Why is that? The reason is that this is because the albumin, it will buffer the acidosis, right? If there is increase in H plus ion, the protein which will buffer that increased H plus ion is the albumin. Now, where is this albumin bound to? The albumin, it is bound to the calcium. So if it wants to buffer the H plus ion, the albumin has to be released from the bound form of the calcium, and it will go and buffer the H plus ion. So increased binding of H plus to albumin results in displacement of calcium from the albumin, right? Results in displacement of calcium from the albumin. So the concept is very simple, right? Whenever there is increase in H plus ion, the albumin which is bound to the calcium come out of the calcium, and it will buffer the H plus ion. Thereby what will happen to the free calcium levels? The free calcium levels increases. Okay, next. Now, we have another clinical condition called familial hypocalciuric hypercalcemia. So this is also one of the conditions which will cause the hypercalcemia, and you need to understand what is the mechanism behind that. So it is a benign form of hypercalcemia, fine, right? And what does it presents with? It presents with mild hypercalcemia, and there will be also family history of hypercalcemia, and urinary calcium to creatinine ratio, if you see, it is less than 0.01, and urine calcium, it is less than 200 milligrams per day, right? There will be hypocalciuria. So you see this, there is hypercalcemia, but there is hypocalciuria. Most of the other conditions, whenever there is hypercalcemia, there will be hypercalciuria also. But here, along with hypercalcemia, there is hypocalciuria. Now, first of all, let me just explain you what exactly is this familial hypocalciuric hypercalcemia. That means what is pathogenesis. So, what is the pathogenesis of familial hypocalciuric hypercalcemia? Now, we have a gene called CASR, right? What does it do? It is a calcium sensing receptor gene, right? It is a calcium sensing receptor gene. And where is it expressed? It is expressed in the kidney and as well as it is expressed in the parathyroid tissue. What it will do? It will sense the serum calcium levels and it will give information to the parathyroid about the calcium levels. Now, in case of familial hypocalciuric hypercalcemia, there is loss of function of this particular CASR gene. That means it cannot detect how much is the calcium. So because of that, what will happen is the parathormone will perceive that there is low calcium, right? The perceived lack of calcium levels by parathyroid leads to excess amount of parathormone secretion. Actually, your CASR gene has to take the information in the serum and it has to give information to the parathormone. But here CASR gene is being mutated. So that is the reason why your parathormone is not getting adequate information how much is the calcium which is present in the serum. So what the parathormone will do? Parathormone will be continuously releasing the parathyroid gland will be continuously releasing the parathormone. So what will be the features? So when the parathormone is excessively released into the circulation, that will cause bone resorption and that will increase the calcium levels. Okay. Now, what are the features of the familial hypocalciuric hypercalcemia? It is indicated by the presence of the hypercalcemia at the same time with hypocalciuria, right? At the same time with hypocalciuria. In all other causes of hypercalcemia, what did I tell you just now? Elevated calcium levels in the blood, right? They correlated with elevated calcium levels in the urine. But this is the exception here, right? This is the exception here, okay? Next, what is the treatment? See, it is a mild hypercalcemia, right? And most of the times they are asymptomatic. So, no treatment is generally required since patients are almost asymptomatic. Okay, so that is about your familial hypocalciuric hypercalcemia. Then followed by that, now you take the hypercalcemia. If at all, if it produces any symptoms, what are the neurological manifestations of the hypercalcemia? Neurological manifestations of hypercalcemia include decreased mental activity such as lethargy and as well as confusion. That will be neurological manifestations of the hypercalcemia. Then what are the gastrointestinal manifestations of the hypercalcemia? Gastrointestinal manifestations, it includes decrease in the bowel activity, such as there will be development of constipation and as well as the anorexia, right? There will be development of constipation and anorexia. And there will be nausea and vomiting. There will be also development of the pancreatitis. So why is that there is pancreatitis? That is due to precipitation of calcium in the pancreas. So that will result in the development of pancreatitis, right? Next. Now, what are the renal manifestations of the hypercalcemia? The renal manifestations include polyuria and as well as polydipsia. Why is that? Because whenever there is hypercalcemia, the individual will develop nephrogenic diabetes insipidus. And secondary to that, the individual will have the polyuria and as well as the polydipsia. Then, the calcium precipitations in the kidney causes the kidney stones and as well as nephrolithiasis. So these are the two renal manifestations of the hypercalcemia. Now, what are the cardiovascular manifestations of the hypercalcemia? Let me tell you, there will be hypertension in almost 30 to 50% of individual. And if you take the QT interval, the QT interval will be shortened in these patients with the hypercalcemia. Now, whenever there is hypercalcemia, how do you treat? What will be the first line treatment? Let me tell you, your main aim is to flush out the calcium out. So for that, what you have to do is you have to give vigorous, right? You have to give vigorous fluid replacement with normal or the half normal saline. Okay, so when there is severe life-threatening hypercalcemia, you need to give vigorous fluid replacement with normal or the half normal saline. And followed by that, you need to give a loop diuretic, right? And the loop diuretic such as furosemide has to be given, that is mainly to promote the calcium loss. That is mainly to promote the calcium loss. So that is about the first line treatment that you have in the hypercalcemia. That is first IV fluids and then the furosemide. Next. Now, what are the drugs which will inhibit the bone resorption? Because hypercalcemia is mainly because of the bone resorption in multiple conditions, whatever we have discussed, right? And in that case, you need to give bisphosphonates, and that particular bisphosphonates include zoledronate or the pamidronate. So what they will do? They will inhibit the osteoclast and they will stimulate the osteoblasts, right? They will stimulate the osteoblast. right? And thereby, there will be inhibition of the bone resorption. Now, when will the maximum effect of the bisphosphonate starts, right? This is little disadvantage of bisphosphonate because the maximum effect, it takes almost 2 to 3 days. Then what is the rescue for 2 days then, right? Until 2 days, if the effect doesn't start, the rescue hormone what we have is the calcitonin. So calcitonin, it will cause more rapid decrease in the calcium levels, right? So meanwhile, the action of your bisphosphonate is going on, right? You can add this calcitonin. Then finally, what is the mechanism of action of the calcitonin? So what this calcitonin will do is calcitonin will inhibit the osteoclast, right? And it will inhibit the bone resorption. That is what is the function which is being done by your calcitonin. So first line treatment will be IV fluids. Then you need to give loop diuretics, that is furosemide, right? And then bisphosphonates, and then we have calcitonin. So this is about the treatment of the hypercalcemia, right? Thank you very much. See you again in the next video.